we looked at RNA sequencing, so RNA-based expression of genes that were either high or low. We looked at DNA alterations, the common ones in kidney cancer, VHL, PBRM1, and the like, and then looked, as we have in the past and others, at PD-L1 staining, and Merck uses what's called a combined positive score with their antibody. So we looked both within arms, so within each arm, which patients did better based on these characteristics, and then also across arms. And I think the major findings are that within the Pembro-Axi arm, patients who are high expressors of what's called a T-cell inflamed GEP, gene expression profile. This is a profile of gene expression that Merck has developed across other solid tumors, namely melanoma and lung, now applied to kidney cancer. Not surprisingly, patients whose tumors had high expression of those genes did better across all clinical outcomes. So in short, more inflamed tumors did better with an immune containing regimen, not surprising. In the sunitinib monotherapy arm, within that arm, patients who had higher expression of angiogenesis-related genes did better. Again, not surprising given the mechanism of the drug. Those were the main findings within arm. When you look across arms, you see somewhat of the same story, meaning that in the inflamed tumors in this GEP high subset, which was defined as the top 2/3 of patients expressing these certain genes, there was a greater split of the curves, and patients did better overall. In the GEP low, the absolute numbers were lower, and there was not much of a relative difference. And that makes sense, right? If you have more inflamed tumors, are going to benefit more from an immunotherapy-containing regimen than less inflamed tumors. So I think it probably mostly confirms the biology of kidney cancer and mechanism of drug, right? In terms of angiogenesis, was really the same story, where you see better outcomes in the sunitinib arm for those patients. Not better than Pembro-Axi, but better than in the low expressors. The DNA alterations, as they have in the past, really didn't show much. There was a response rate difference in PBRM1 mutant versus wild type within the Pembro-Axi arm, but none of the other DNA alterations were significant. PBRM1 has variably been shown to be significant or not significant with response to immunotherapy, so it's a bit of a mixed story depending on data sets and which line of therapy. And so this sort of adds to that data, but again, I'm not sure that it's clinically actionable. And our therapy in kidney cancer is attacking the stroma. It's attacking immune cells and blood vessels, not the tumor itself per se. And that's probably, in my opinion, why DNA alterations, which are obviously tumor-based, are not as relevant as a biomarker. And then lastly, PD-L1 was really not associated with outcome. It was negatively associated with survival in the sunitinib arm, which has been shown before, but it's just a poor biomarker in kidney cancer. It doesn't select well. And, again, there's all sorts of heterogeneity in PD-L1 expression and measurement, but it unfortunately hasn't proven reliable or useful.